Hi, welcome back to Ahead of the Curve. This is your host, Dr. Megan Teed, and I'm here this week with a very special guest, Dr. Mary Grimberg, and she is joining us from Austin, Texas. Today, we're going to be talking about our week 3 topic of things to do with scoliosis, pregnancy, preparing for pregnancy, being pregnant, and postpartum. So this week we're going to be talking about considerations for postpartum recovery with scoliosis. And I'm really excited to get Mary's perspective on things. Welcome, Mary.
Thank you. I'm excited to be here. I appreciate you asking me to be on here and helping your audience understand how they can better move during their pregnancy and postpartum.
Awesome. So for those of you who aren't really familiar with pelvic health or what a pelvic health therapist does, Mary, can you explain a little bit about what it is that you do and why someone might need you?
Yes. So pelvic floor physical therapy is just really an addition to orthopedic physical therapy. And so what I mean by that is, we look at how the body moves, how your hips move, how your back moves, how your mid back moves, how your balance is, and all these different things, and how they work all the way up the chain into the pelvis and then the pelvic floor. And so a lot of people don't know what the pelvic floor is, but it's actually a series of muscles that they're kind of shaped like a hammock, right? And so in that hammock, they hold our pelvic organs. So it holds your bladder, it holds your vagina, uterus, and rectum. And so all those guys sit on what looks like a hammock, but it's actually the pelvic floor muscles. And these muscles function like every other muscle in our body, just like our bicep, but we don't think of them in that way. But there's 3 muscle layers. There's the first layer that surrounds the vaginal opening and then around the anus. There's a second layer that's sandwiched between the first and the third. And then the third layer is where those organs sit on top of. And so as a pelvic floor physical therapist, I'm looking at your pelvic floor strength, your diaphragm, how your diaphragm works with your pelvic floor. So your diaphragm attaches to the lower ribs and it's shaped like an upside down bowl. And then your pelvic floor is shaped like a bowl. So they work inversely. So basically what that means is when you're breathing through your diaphragm contracts, so it pushes down and then it lengthens the pelvic floor. And then as you exhale, pelvic floor comes up and diaphragm relaxes. So they work in unison together. And so that's a big function of the pelvic floor as well. The deeper abdominal muscles and then the deeper spinal muscles. So all of those directly affect the pelvic floor. And as a pelvic floor therapist, I'm looking at mobility, like how are the muscles moving, how are they contracting, how are you experiencing symptoms, and just really assessing the overall person in front of me, if that makes sense. And part of the assessment can be with in person, it can be an internal assessment if people are comfortable with that. And what that means is I'm really looking at the tissues on the outside of the vulva. So the vulva is really everything around the vagina. I think we tend to call just anything down there vagina, and it's actually vulva. So around the vulva, I'm looking at the tissues around there. If there's redness, if there's irritation, if it's pale, if there's any abrasions or anything along those lines. And then internally, I take my index finger and go through each into the pelvic floor muscles, and I'm assessing if they're tight, if it produces any of your symptoms, and then your ability to contract and relax your pelvic floor muscles. And most people actually do Kegels wrong. And so just even knowing how to do them right can make a big difference. But pelvic floor physical therapy is, as you can tell from everything I described, is not just Kegels. And it
Yeah.
never will be. So just want to kind of get that out there. Get it
Public
out.
service announcement.
What's that?
I said public service announcement.
PSA. Yeah. All of a sudden, everybody's going to get the alerts on their iPhones.
Yeah. So just kind of branching off of what you were just talking about, what do people do wrong when they're doing Kegels? Like, what
Well,
is the
I think the
problem?
biggest component is that people aren't pulling up. So they're squeezing. So like a pelvic floor contraction should essentially just be like you're trying to hold in your pee and poop.
Mhm.
And sometimes people just squeeze their butt, and that's not actually squeezing the anus. And then it's not squeezing the opening of the vagina. And so the biggest thing I'd say people do wrong is they don't pull up. They just kind of contract a little bit, or they squeeze their butt and their inner thighs. So
Mhm.
those are kind of the bigger things. You shouldn't be able to tell that you're doing a Kegel. Like you shouldn't be like moving your whole body up and
Well, funny
down.
down.
Yeah.
Yeah.
If you do, then people will be like, "What are you doing?" And you're like, "I'm doing Kegels." And they're like, "No, you're not.
You're doing it wrong.
Get out of here." Yeah. No, I mean, it's common though. Like a lot of people do. I mean, how would you know? It's not like we learned this in school.
No, no. Or your parents definitely don't teach you how to do.
I never got that. Yeah, that wasn't in my sex talk.
Oh my
But
gosh.
yeah, I have fun with it. So we'll talk about a lot of poop, buttholes, vaginas, all the things.
Yes. Yeah.
Yeah.
So you were talking a little bit, I'm still on your first your first question, but you were talking a little bit about breathing, the diaphragm and the pelvic floor connection. And with scoliosis, we certainly have so many asymmetries.
Yes.
As far as, we have these hollow areas that there's a lot of like compression in those areas of the diaphragm. And then we have the convexity or the prominence where it's much more open and
Mhm.
expansive. Have you noticed anything as far as like any patterns with people with scoliosis, as far as like breathing issues or pelvic floor issues in relation to those asymmetries, or not really so much?
Yeah, I mean, if you think about it just from like a mechanical standpoint, right? If we're on a podcast, so I don't know if they're going to see this video or not, but basically, like as the diaphragm pushes down, the pelvic floor lengthens. So if you're compressed one side on the diaphragm, you may not get that expansion as much, maybe lower down. But that doesn't mean that it can't be helpful. It's just that maybe we kind of open up. Sometimes we can do kind of some side lying and open up and try to really breathe into that area and kind of get into a position that can help you expand a little bit more. I actually find from the front side aspect, like being more compressed on that side, you can actually go in and release the diaphragm and kind of relax some of those abdominal muscles along the area. So even just kind of massaging those muscles, I think we miss a lot of stuff in general by not assessing how tight the abdominals can be and how that can affect expansion of the diaphragm.
Yeah. Yeah.
So I'd look at, opening up more of the abdominals, getting into positions that would potentially take off some of that compression, and then really trying to focus that breathing into that area if possible, depending on the severity of it. But overall, even just learning how to diaphragmatically breathe in general, kind of when you can, kind of stacking the ribs over the pelvis can make that difference. But if we're sitting and we're hunched over, what happens is the diaphragm shifts forward and the pelvic floor stays back. So you don't really get that downward pressure. So that upright posture is going to make a big difference, more so than it would with scoliosis, if that makes sense.
Yeah. Yeah, totally.
Right?
Mhm.
Hmm.
So what led you to specialize in pelvic health when you were making that decision?
Yeah, great question. So I have been a orthopedic physical therapist, basically just treating, everything: back pain, neck pain, shoulder pain, really since I started and being a physical therapist, and I graduated in 2011. And I did an orthopedic residency, which was another year or so after school, sat for my boards to become an orthopedic certified specialist. And then I was also doing continuing education and teaching for the certified orthopedic manual therapy programs. And what I was finding is I was doing all of these latest and greatest techniques and exercises, and my certain subset of my clients with pelvic floor dysfunction were just not getting to the point where they should be. And, I'm doing the things, I'm talking with the patients, they're doing the exercises, and it just felt like this huge piece to the puzzle that I was missing. And to be honest, I was hesitant at first because, it is it can be you're doing an internal assessment, and a lot of times you don't even need to necessarily do an internal assessment. It can give you some information, especially like with skin irritation and stuff like that. But other than that, it was just more of me not understanding how it incorporated so easily with orthopedics, because you're looking at the entire body. You're not just looking at the pelvic floor. And so I did feel like having that kind of background made me a stronger pelvic floor physical therapist, because I don't just look at the pelvic floor.
Yeah.
And yeah, and I'll give you an example. Like I have a patient who just when, playing golf, they'll only leak when they're hitting a longer drive versus like a shorter one. And so that's not a Kegel problem. That's okay, well, what's going on? Or, what's their hip mobility like? Like, why is it that they're only experiencing with this, not anything else? And so it's like, if you can't generate that force, you're increasing the intra-abdominal pressure. So then the only thing that can kind of go is down. And if you can't get that hip rotation or the thoracic rotation, you're going to take up all the slack in the areas that are left, which is the lower abdominals and pelvic floor, if that makes sense. So that's why Kegels aren't the answer, because we have to
Yeah.
look at all of these different things.
All the things.
All the things.
So kind of onto the topic of the week, I asked my followers on Instagram what they're most interested in learning from you in regarding to the afterbirth experience and having scoliosis. There's just a lot of fear. There's a lot of uncertainty, things that are unknown as far as being pregnant and the journey afterwards with scoliosis. Like basically, like you're told crazy things like your curve will definitely progress and all these things. So really excited to get your perspective on some of these things. One of the questions is, do you have any advice on the sitting position for feeding for somebody with scoliosis?
So that's a great question. My biggest thing with feeding is if you can breastfeed from both breasts, just making sure that you're in a position that's comfortable for you and baby. A lot of times people kind of hunch over, and making sure you can hold the baby, place some pillows, and having the baby their face and their feet facing you, so that way the baby's not straining with their neck as much, and then you're not holding in these awkward positions. And so I'd say one of the biggest things that I see is that people are hunched over when they're breastfeeding, which is also like, I mean, hey, you're gonna do that if you're breastfeeding in the middle of the night, you're exhausted. Like, let's be realistic. But if we want to get down to the nitty gritty, yeah, look at these positions that help you, that are the least minimal effort, right? So like if we're looking just at just ergonomics, right? So if you're sitting at a desk all day, it's not, you want to get a setup where you're not exerting so much energy to hold yourself up. That is a true ergonomic setup. Like it reminds you how to sit, so that way your muscles don't have to do it the entire time. So what can you do to set up the space that you're consistently breastfeeding in? Obviously, this is going to change if you have to go to work and different things like that and pumping, but what can you do to kind of make it so you're not having to lean forward, that you're not having to hike up your shoulder or side bend your body? Like, what can you do to kind of help support the baby, so that way you're not leaning into those positions as much, if that makes sense? So a lot of pillows, and yeah, just doing as much as you can to kind of be more upright and not as much hunched over, and use a lot of pillows or support. There's some different things you can use for that, but that's in an ideal world, but do the best that you can.
Yeah, that makes a lot of sense. And I never even thought about just turning the baby, making sure that they're facing you. That seems like something that would be so simple, but I'm sure it gets missed because it's just, you're just
Well,
trying the best you can.
well, it's crazy because I actually, so, we've talked, but I'm writing a book on preparing for postpartum, essentially. It's just called Body After Birth. And I interviewed a speech pathologist who specializes in breastfeeding and helping the baby latch. And that was one of the biggest things that she said, one of the many pearls that she gave me, but it was making sure baby's head and feet are both facing you. It's good for you and the baby, because then the baby's going to be overusing a lot of their neck muscles, and then it just kind of changes how they're able to
Wow.
pull suction the milk from the breast.
hmm Yeah, amazing.
Yeah.
So for wearing the baby, carrying the baby around with scoliosis, we tend to generally have a hip glide off to one side or the other. And it's funny, I start working with people and they call it their baby carrying hip because it just, it's just a perfect little shelf for the baby to rest on. And obviously we don't want to be perpetuating or encouraging those positions after we have a child. Do you have some recommendations for some better techniques or better ways to carry or wear the baby?
Yeah, I mean, I would say you can carry the baby in the front, the baby Bjorns. You could do that. That's going to help you avoid kind of these asymmetries. But, that takes time to put the baby in. And, sometimes you don't have time to do that. So I would say, if, because I want to be realistic too. I can be like, oh, hey, let's set this up perfectly. And, people that have multiple kids are like, what is this lady talking about? This isn't that realistic. So there's that. But also, okay, if you have that hip glide, it's probably going to be harder to kind of, my biggest thing is always like, try to decrease asymmetries when you can. And
Mhm.
so maybe in this case, like you hold more on the left side. If you can't rotate and do the other side, maybe you do some strength training to kind of help promote that stability on the opposite side, so you're not constantly hiking up that left side. Does that make sense?
Yeah. So, like basically just trying to find that balance before you start carrying the baby around. Like,
Yeah, because it's like, if you're having that hip glide onto that side, it's going to be harder to kind of shift to the other side,
yeah,
correct?
yeah.
So what can we do to counteract that?
Mhm.
And okay, well, if your go-to is going to be you got to pick up the baby pretty fast and kind of go on with your day, you're probably going to toss the baby on that left side or whatever side the hip glide is on. And
Mhm.
so what can you do? The goal is to kind of make sure you're getting equal force kind of on both sides. So like you could do unilateral like farmers walks or something like that to kind of build up the strength from the opposite side, so it's not all the left side or whatever side you're carrying on is getting all of the action. Does that make sense?
Yeah, it totally does. Yeah.
And so, you and I have talked, like, a lot of my programming, even for people without scoliosis, is the like one-sided movements, because being a parent, you're not just doing things like, you're not just squatting with a weight in the middle of your chest. Like, you're squatting in an awkward position, you're picking up a baby from the ground, and then you're doing, 50 other things. And so, how can we best get you into this strengthening or stability to help you with your day-to-day stuff? And usually that's going to be, okay, how can we kind of mimic that on the other side if you can't hold the baby on that side?
Mhm. Yeah. Yeah. That makes a lot of sense. So basically like training up the other side
Yep.
to,
And yeah, exactly. Or if if it's gonna you're holding the baby longer, then maybe, yeah, wearing the baby in the front if you can. And then with that just means that, you're constantly strengthening the backside of your muscles, because
yeah.
you're gonna be holding up. So
Mhm.
all in all, it's just coming down to how strong are you from side to side, not just both sides.
Mhm. Yeah. Good. So kind of along the same lines, kind of carrying around a car seat,
Hmm.
super awkward, pretty heavy.
Yep.
Do you have any suggestions for carrying that around without injuring your back or
It's gonna
just
be that same type
same
thing,
idea?
right? Like, the farmer's walker, you're holding like a kettlebell and then you're trying to keep yourself upright. Where I find is people, their backs get irritated and things like that, is that they don't have the strength because, those can be pretty heavy with a baby inside. You're
Mhm.
looking at sometimes 20-ish, 25, 30 pounds, depending on the size of the baby, who knows? But, and if you haven't strength trained, that's going to be really hard. So how can we, get those movements and practicing? Yes, I could give you like these specific, like you can try to move like this or like that, but the reality is putting the car seat in the car is awkward. Like you're not going to get out of step stool and then side bend this way and then rotate. Like,
Oh, you're not?
no, yeah. And
Like
yeah,
80 hours just to get to the grocery
yeah. It's like,
store.
forget it. I can't go to the grocery store. I can't do my 90-degree angle with the hip rotation to the left.
Yeah.
Um, and so, yeah, so like I said, it's going to be how can we kind of practice those movements in your workouts,
Mhm.
and maybe it's not that you do 30 pounds walking with a weight on one side. Maybe you do like 15, go to fatigue, or you time it and then you switch and do the other side. And you'll actually find when we start doing this, people are like, oh my God, I had no idea this side was weaker than the left or the right. And it's like, well, you haven't done most training, and most postpartum training is not as much one-sided and kind of these
Yeah.
functional movements as I would like it to be, you know.
Mhm. Yeah, that's certainly really important. Kind of
Totally, yeah.
kind of a theme here.
One-sided left, we could just end this podcast. Just lift weight on one side.
The end.
The
Yeah.
end. You're like, wow, she was very informative. You can never have her on again.
So a lot of new moms that I work with, they are really active.
Huh?
They want to be getting back to running, lifting weights, bike riding, all the things. And there's not a whole lot of guidance as far as like returning to stuff like that. Like basically 6 weeks, you go and your doctor says you're free to do whatever you want.
Mhm.
Um, is there like a better way or a way that you recommend kind of gearing yourself back towards these things?
Yeah, no, like there's a few different things. And so a lot of times it's just kind of easing into certain activities. And so I'll give you some examples. So say, let's just kind of go back to the basics. Like your abdominals were overstretched, right? For, 9 months or so, right? Give or take. Like maybe the beginning, not as much, but whatever. The point is like they were stretched out. And so let's compare that to like your bicep. If your bicep was, so if your elbow was fully extended for 9 months, and before that, you were able to lift like 50 pounds, right? And then you fully extend it for 9 months. And then after the 9 months, you're like, oh, okay. And then you try to lift the 50 pounds again. In
Yeah.
this case, your bicep is going to develop tendonitis if you keep doing that because it's just the load. It's too much. So,
Mhm.
where I would start with that is maybe I'd start at like 5 or 10 pounds, see how I feel, do like some repetitions, 10, 15 reps, see how you feel, kind of assess how you feel the next day. And the abdominals are the same way. I find that pretty much most people that I see, they're trying to get right back into where they were
Yeah.
pre-baby. And it's just not realistic. And Instagram doesn't help with this either.
Mhm.
Sometimes these unrealistic expectations, these people. I just saw somebody the other day. They're like, look at my belly 8 weeks postpartum. And it was like a 6-pack. And I'm like, it's not
Yeah.
realistic.
Yeah.
And that can affect people pretty significantly to see that because it's just not reality. And so where I would start is like, okay, well, most people, when I see them, they're like, I have back pain when doing abdominal workouts. And I look at their abdominal workouts and they're going straight to a full plank. And, they might have some diastases, which is the spacing of the 6-pack muscles because the pressure, it's just too much that the force is kind of going outward and they're not feeling it in the abdominals and they're feeling it in their glutes or back because something needs to hold them up. And
Mhm.
so instead of going straight to a full plank, I often have people do planks along the wall for a week or two and kind of reassess, or 3, depending on how they feel. And, this can be dependent on, it's going to take longer if you've had a C-section or multiple C-sections than it would for somebody that maybe vaginally, and maybe it was their first pregnancy, or, everybody's so different. And so that's one of the biggest things that I would say is like scale back before scaling up again. And thinking about, I've heard people being told when they have the diastases or the separation, like you can never do a crunch or plank again. And I hate, I know hate's a strong
Never.
word, but I very, very dislike when people are told these all or nothing things. And I know your audience hears that a lot, and it's a huge pet peeve of mine because it just does not empower people, and it instills fear. And what's worse than fear of movement? And then you just don't move. So now you just scared people into not moving. And the answer is not stop doing those things, it's modify them. So if a crunch bothers your back, or it feels like it's really hard, maybe you just lean back into a chair and then pull yourself up, right? So you kind of change the angle a bit. So, and at the further away you go from your butt, like from the pelvis, the harder it's going to be, right? So the lower to the ground you are, the harder it's going to be. So it kind of goes back to physics and understanding, like, as you go further away, the harder it's going to be. So sometimes I'll have people, they're laying on their back and doing the flutter kicks, like that are just like right above the ground. And I'm like, that is super hard to do
So hard.
in general. And they're arching their back, and then they feel it in their hip flexors, and somebody's accidentally peeing or farting. And I'm like, this is a lot. Okay. This means it's too much. And we normalize it because it's like, oh, I'm never going to feel that again. I had a baby, so I can't, whatever. This is my new life. And that's absolutely not the case. So instead of doing the leg straight, I would have them lay on their back, knees bent, and maybe alternating like kind of a march, lifting their legs up that way, and then gradually progressing to the legs further away.
Yeah.
So that is the biggest thing that I would say for exercise. And the other thing that I will say is that they did release some guidelines for like postpartum return to running, and the general consensus is about 12 weeks. But what that means is it may be sooner for some people, it may be later for some people, but that doesn't mean you can't work on stuff up until that point.
Right.
And so some of the things that I have my clients work on in the program that I'm working on is the gradually progressing up to that, right? So if you want to get back to running, we have to get you a lot of that one-sided strengthening, single leg stability work, and then impact with both feet, impact with one foot, and then you start kind of the interval. So you walk for a few minutes, then jog for a few minutes, and then eventually those intervals increase in the jogging and decrease in the walking. So it's really like, I know there's a lot of fear around it, but when you break it down this way, it's a very safe way to progress. And then you just check in with your body. Like, how am I feeling? Do I feel good the next day? Does this hurt? Okay, well, it doesn't mean you need to stop. It just we need to stop and reassess very objectively and look at, what did I do the day before and how could I modify it next time? Which is simple to say objectively, but when you're anxious, your subconscious brain is like, oh my God, I can't do this again. I have scoliosis. Like, my doctor told me there's nothing they can do. And the reality is, when people say there's nothing you can do, it's usually because they don't know.
Yeah.
They don't know. And so in that case, they should just say nothing instead of fear-based stuff.
Right.
So I'm very pro movement, if you can't tell.
Yeah. So if you're told that, find somebody who can do something, there's always someone that is able to help you, through your situation.
But it's not even, it's in scoliosis, but it's also in general healthcare. Like, I had somebody the other day, they were told never to squat again. And I'm like, how are you supposed to poop? Are you supposed to poop standing up? Somebody show me how to do that.
Why were they told that?
Because their knees.
Oh yeah. Okay. Yeah.
I'm like, okay, let's, or even with runners. Oh, you're hurting your joints. Well, If you progressively load it, I mean, if you go from not running to running a marathon the next day,
Mhm.
yes, that
Yeah.
will hurt you. But if you're like, like going and easing into it and gradually loading your body and doing strength training as well, you'll
Mhm.
likely be fine.
Yeah.
And the people, you have to look at who is saying this. Are these people that are musculoskeletal experts? Are they experts in the field of what you are suffering from?
Mhm. Yeah.
And, you
So
know, yeah, yeah.
yeah. So moving on to a different question. Painful intercourse is an issue that like a lot of folks that I work with in general have, and then especially with new moms um, who have scoliosis. Is this something that might have happened as a result of their pregnancy and their birth, or um, and if so, or if not, like, what might have triggered this, and then how do you address it?
Yeah, I see this a lot. I see it a lot. And it's a very loaded thing because it's multifactorial when we start talking about pelvic pain during sex. And so in this case, penetrative sex. And so if we think of the pelvic floor muscles, like I said, that bowl, like I told you about,
Mhm.
okay, they're it's shaped like a bowl. And around the vaginal opening, there's muscles that surround that too. And so sometimes there's pain with initial penetration, and sometimes there's deep, and sometimes there's both. And so, generally speaking, if we're just talking about people that have not had children, what I find is a few different things. Number one, misinformation. A lot of people are ignoring the clitoris because they see on TV people are ripping off clothes and sticking, you know,
Yeah,
penises
going
and
at it.
vaginas or dildos and vagina, whatever. And it's like the vagina doesn't work that way, and a lot of the stuff that we've seen on the media is very geared toward like men. And I think that that's very harmful for, we're just saying men and women right now.
Yeah.
But it's very harmful for the person with the vagina to hear that because they might think that there's something wrong.
Mhm.
And we need the clitoral stimulation before, so basically foreplay, before penetration, because what happens is physiologically when the vagina is aroused, it dilates, so it opens, and then the uterus and cervix rise up, so it lengthens the vaginal wall.
Mhm.
Okay. So pain with sex can happen if there's not enough foreplay because it's trying to stick, I don't know if I just give this example. It's like, it's trying to put a tampon in when you're not on your period. That dry, we've
Yeah.
all had it where you're just like, oh, this sucks. Right.
Yeah. Yeah.
Like, that's kind of what it's like. And of course it's going to hurt because the cervix is lower. So you can be hitting the cervix more easily. And then your muscles are tense, they're not relaxed, the vagina's not dilated. That's a big component because of the society that we live in, where the focus on sex and penetrative sex is around penile vagina penetration, but mainly focused on the male perspective. So that's really something I'm very passionate about, like telling people sometimes it can take upwards of 45 minutes for somebody with a vagina to experience an orgasm. And what
Mhm.
we see on TV is 2 minutes.
Yeah.
Like, they're ripping off clothes, having sex in a library. I'm like, what library? Like what library are you doing this? Aren't you worried that like the books are gonna fall? Like somebody's gonna catch you, and then you're orgasming within 30 seconds?
Yeah, that's very, yeah.
Like, who are you and why? And I just can't. And so the point is that's one big reason why you can have pain.
Mhm.
Next can be vaginal dryness. And you'll know if it's vaginal dryness because sometimes it feels like it's just dry. It feels like there's little micro abrasions, like burning is a big one that people will feel. And just feeling friction. And that can happen for a variety of reasons. Sometimes it can happen when you're breastfeeding because the estrogen decreases in your vagina, and then that leads to a decrease in estrogen, that leads to a decrease in lubrication.
Mm-hmm.
So that can be another reason why there's pain with sex. That can also happen if you're going through cancer treatment. It can also happen when you're in perimenopause and menopause as well. So, it can happen. And sometimes it can happen when you have estrogen changes from oral contraception too. So sometimes people just have different effects based on medications. Um, those are sometimes the most common, but I'd say breastfeeding and perimenopause and menopause are the most common. And like I said, with sometimes with chemotherapy and radiation, that can happen as well. And if it's a lubrication issue, I tell people a couple different things. Number one, there's something called lube launchers, and I wish there was a more professional term. Like when I tell people, I'm like, I'm Dr. Mary, and my suggestion is lube launchers. So basically they look like tampon applicators, and you fill them with lube and it shoots up your vagina and it lubricates deeper, because if you just put in lube on the outside, it doesn't go as deep. So that's a big way that people can help with that. Second would be, there's something called Reverie, and it's basically hyaluronic acid tablets that you can put in your vagina to help lubricate it, just kind of throughout the day, so that when you do want to have penetrative sex, it's already lubricated. Downside is it can be a little pricey. And then the next thing would be vaginal estrogen. And you can talk to your OBGYN about that. Some people don't like to go on estrogen. It just depends. But those are like the main three options for that. Another reason why you can have pain with sex is, I just did a post on this on Instagram, but it was basically you can, from tearing during childbirth, if you think about the vagina as a clock. So 12 o'clock is going to be like the clitoris. 6 o'clock is going to be the backside of the vagina closer to the anus. And usually around that 5, 6, 7 o'clock is where vaginal tearing can occur after giving birth. And that scar needs to be moved once it's closed. And, I've had people say it feels like I'm having sex and it's just like glass. They feel like it's glass. They're like, ow, what did you put in me? And it's like, no, it's the scar, because scars bind down to the tissue and they don't allow it to expand. So it's really going to hurt sometimes if you don't move it. Sometimes people don't have symptoms and sometimes people do. But moving that scar can be beneficial as well, because it's like scar tissue in any other part of the body. And then finally, one of the biggest things that I find, and it just depends on the person, is there's just so many different types of pain with sex. And so another one can be,
That was a loaded question.
I know, but I think
do a whole episode probably on that.
I could do a whole episode on this. And I just love this. I'm just very passionate about it, if you can't tell. And unfortunately, there are a significant amount of people that have experienced sexual trauma. And so sometimes what I find is that with unhealed trauma, and not working necessarily with like a therapist, or not even knowing, sometimes people don't even know, their brain just kind of blocks it out, can cause some pelvic tension when there's any sort of sexual activity, because the body's just trying to protect itself. And so when that's the case, and I find that, when it is, I have make sure that if they can, that we're talking with a psychotherapist that specializes in sexual trauma, and we work together, because it's not just a pelvic floor thing. It's a relationship thing with your body, with your partner, if you have one, with your surroundings and all these different things. And also if you're chronically stressed, right? So when we go into fight or flight mode, which is the sympathetic nervous system, what do? We tense our jaw, we hike our shoulders, and we squeeze our butts and vaginas. And so if you are in that mode and then you try to have sex, your body is in fight or flight. So it's not ready for penetration necessarily. So anyways, long story short, it can be a bunch of different things. And then finally, breathing through the diaphragm can help relax those pelvic floor muscles. So it's a big thing there. Sorry, I just went on some but I want to make sure we went over a lot of things. And there's
Yeah.
also inability to tolerate penetration as well. And that can be treated, and that's called vaginismus, when people can't even be penetrated by any means. And it can be treated in physical therapy. It just takes a bit more time.
Yeah. Yeah. I think it's important to touch on all of that because, you can feel kind of alone in that situation because not a lot of people talk about it. It's, they see, like you said, they see Hollywood and they're like, well, there's obviously something wrong with me.
I know. If I'm not having
not
sex in the
happening for me.
library, yeah. Like, first of all, I got to get a library card.
Library orgasms. Yeah. So
Library orgasms. Whatever. Yeah, I think it's important. And I think that the people that I have had that I've talked to, I'm the first person that they've talked to about it. And also, unfortunately, I'm a lot of times the only healthcare provider that has talked to them about sex.
Yeah.
So it's like, oh no, I don't want to talk about sex. It's like, come on.
Yeah.
Let's just
Exactly.
yeah.
This has been such a fun conversation. I really want to have you back on. But you have a lot of exciting things coming up and things that you're planning. We'd love to hear about what you have on the docket for the year and maybe upcoming years.
Yeah. So as you can tell, I'm very passionate about the pelvic floor and helping people understand their bodies better. And so in 2023, I will have finalized a book to help you understand your body postpartum. And it's called Body After Birth. So you can understand a lot of these things a little bit more in depth and have a really good baseline and resources of where to go from the book, or some understanding of your new body after birth. So there's that. And then I'm also working on some postpartum training programs, some that are on how to reduce leaking, and then some exercises to, like I said, kind of a lot of focusing on that unilateral, one-sided movements to help people return to running and exercise without leaking, but just in general too. You can use a similar program with the exercise to help people get back to exercise without the fear of movement. So you will never hear me say any type of fear-based thing. And if you do, I don't know, then I don't know, I should retire.
You owe them a Coke.
I know. Or retire. This is the only answer. It's send me a message on Instagram. Please retire.
Please retire. Quit your job.
Quit. You suck.
So how can people find you if they want to work with you? You're doing some online stuff. So tell us your Instagram, your website, all the things.
Yeah, they can follow my Instagram, and then on there I have a bunch of the links. It's Dr. Mary PT. And they can follow me, and I go over a lot of these questions in my reels. And as you can tell, I'm a bit of a weirdo, so that kind of reflects in some of my reels sometimes when I'm fake breastfeeding my dog. I don't know if you saw that one. And I was like, okay, let's just see if I'm sure I got some unfollows and probably who?
What's happening here?
What's happening? I don't know. My big thing is I like entertaining while educating.
Yeah, I think that's important because some of this is just so really hard stuff, and life is hard. So
life is hard.
It's fun to have levity to it while you're learning. And I try to do the same thing. So it's been really a breath of fresh air to have you on and talk and laugh with you and learn.
Yeah.
Thank you so much for sharing your expertise.
Well, thank you for having me.
Absolutely. All right. Well, that is it for today. We'll catch you next week on Ahead of the Curve. Have a great week.